Here are my disclosures. And my first statement is that plantar plate dysfunction leads to MTP joint instability. And instability of the MTP joint is evil. Why is it evil? Well, it leads to things like metatarsalgia, synovitis of the MTP joint, and even hammer toes. The way that plantar plate instability can lead to a hammer toe is that the plantar plate will tear or stretch, and that will lead to dorsiflexion of the MTP joint. When the MTP joint becomes dorsiflexed, the intrinsic tendons are displaced dorsal to the center of rotation of the MTP joint, which further dorsiflexes the MTP joint. And as the MTP joint is dorsiflexed, the FDL tendon becomes stretched and will start to flex the PIP joint and lead to flexible contractures and eventually a fixed contracture and a rigid hammer toe. The plantar plate is a ligament on the plantar surface of the MTP joint, and it originates from the metatarsal as well as the plantar fascia, and it inserts onto the base of the proximal phalanx, seen here. And it is the primary stabilizer of translation and hyperextension in the dorsal direction. And this figure here is showing where the plantar plate is originating from the metatarsal neck as well as the plantar fascia. A closer look at the origin on the metatarsal neck is seen here, and this structure has been described as a loose and fragile synovial tissue, but I think that it's a little more robust than that and probably contributes a little more to the plantar plate stability, and I'll get into that later in this talk. How do we get tearing or stretching of the plantar plate? And it's usually multifactorial. One reason is inflammation. A mechanical reason could be a long second metatarsal. Hallux valgus can do this, where the big toe is pushing against the second toe, which eventually can lead to stretching of both the collateral ligaments as well as the plantar plate. Acute trauma is less common, but can definitely lead to plantar plate tears. Repeated steroid injections can also cause this and can cause attenuation of the plantar plate. And then another mechanical reason are things like gastrocnemius contractures, where in a gastroc, if you have a tight gastroc, in the gait cycle, it leads to forefoot overload and eventually can lead to attenuation or tearing of the plantar plate. When patients present clinically, they often complain of pain at the MTP joint. They may have a subluxated MTP joint, and we can see foot deformities such as this. The most sensitive and specific test for detecting MTP joint instability is the drawer test. And so here's a normal side where, and this is the abnormal side, where you can see that dorsal translation leads to significant motion at the MTP joint. And so this is the abnormal one. This one is the normal side. And again, here's the abnormal side. When we get imaging, we always start with radiographs. We won't directly see a plantar plate tear, but we can see associated pathologies such as hallux valgus, long metatarsals. And then in cases like this, we can see some rotation on the left second MTP joint, as well as some medial deviation of the toe. And on lateral images, sometimes we can see things like this, where we see the second toe is floating and is dorsally displaced. Ultrasounds can be useful. I don't typically get ultrasounds, only for, I don't really know how to interpret them very well. I will get MRIs occasionally for this. And what we can see here plantarly is the plantar plate in this case is attenuated, and we don't see a nice thick black line. What we see here is hyperintensity within the plantar plate on the plantar surface. And we can sometimes see other things such as MTP joint synovitis seen here on the dorsal side of the joint. Now, we're talking about plantar plate tears. It comes in a lot of different flavors, ranging from a grade 0, which is a stretched plantar plate. And then your grade 1s are the partial tears. And as you go to grade 2, 3, and 4, we see larger and larger tears. Treating these, initially, we will always treat these non-operatively. In the setting of a tight gastrocnemius, we will do calf stretching, and this calf here is stretching. So we'll do calf stretching to help release some of the overload on the forefoot. Footwear modification, such as wider shoes or a bigger toe box or metatarsal pads, are very effective at not fixing the problem, but helping with symptoms. And other strategies, such as a boot and splint, is meant to stabilize the toe against hyperextension or dorsal translation. So a boot and splint like this is helpful, and occasionally we'll use tape as well. However, tape has some problems and it'll leave some sticky residue on the skin. Does non-operative treatment work? Well, as far as we know, the plantar plate, is it going to heal? We don't really know. So our group did a study where we looked at the microvasculature of the plantar plate, because we honestly never really knew the blood supply of the plantar plate. So in this study, we found that the blood supply to the plantar plate is coming from both proximally from the bone and the plantar fascia, as well as distally coming from the phalanx. And then the middle of the plantar plate is relatively devoid of any blood supply. So that reminds us of another structure in the human body with, like the meniscus, where we have good blood supply around the periphery, but then you get to the red and white zone, which has less blood supply, and then the white zone, which is relatively devoid of blood. So in terms of surgical treatment, there's been several things described, such as synovectomy, syndactylization, which I don't think is used very often, collateral ligament reconstruction, tenotomies, MTP joint fusions, tendon transfers, Weill osteotomies. And with all of these different strategies, we have seen residual deformity in approximately 25 to almost 40% of patients. So that's why we've gone on to more anatomic repairs, such as a plantar plate repair. And there have been the plantar approach described, as well as the dorsal approach. I've never really done the plantar approach, but as described here, it's a plantar incision, and dissection is taken down to the level of the plantar plate, and a direct repair can be carried out, as seen here. The more traditional approach is the dorsal approach, and what's been described is a dorsal incision, and you retract the extensor tendons. And one of the issues with this is visualization and exposure of the plantar plate. So what's been described is placing a maglanory elevator to release the plantar plate from the metatarsal neck, and then a plantar condylectomy will be performed to give something for the plantar plate to heal to proximally. And putting in this maglanory elevator, as you can see here, we're stripping that proximal attachment off of the bone. And in doing so, as described by Coughlin and Jastifer, when you put that maglanory elevator in there, you'll get about 4 millimeters of additional joint distraction to give you visualization of the plantar plate. After the maglanory is placed, next a Weill osteotomy is performed, so a saw cut of the metatarsal bone, and then the metatarsal head is actually pushed proximally and pinned into place to gain access to the plantar plate. The joint's distracted, and here's your typical view of the plantar plate. And the next step is to cut the plantar plate off of the proximal phalanx, and that will give you additional room to work in there. So after the maglanory elevator is placed and you get about 4 millimeters of distraction, release of the plantar plate gives you an additional 5.3 millimeters of distraction. And I'd like to point out here that the maglanory elevator and releasing the plantar plate off of the metatarsal basically gives you the same amount of joint distraction as completely releasing the plantar plate off of the proximal phalanx. And that'll come into account later when in this discussion. But after the plantar plate is released off the proximal phalanx, suture passers are then used to pass the suture into the plantar plate. After the sutures are placed into the plantar plate, 2 drill tunnels are placed through the proximal phalanx, and a suture passer is used to retrieve those sutures from the plantar plate to the dorsal portion of the proximal phalanx. After that, the metatarsal head is replaced, and a screw is used to hold your Weil osteotomy in place, and the sutures are tied, and this is typically what it looks like at the end. And here's a patient of mine where I did that same repair and improvement of their alignment, but you can still see that there is some deformity there, and a little bit of a floating toe. And so the prospective outcome studies from this show that even with this method of an anatomic plantar plate repair, we will still see some floating toe in anywhere from 17 to 60% of the patients, and we'll see more residual deformity in higher grade tears. So why are there still floating toes even with an anatomic repair? Well, one question is, with the current methods for plantar plate repair are we killing the plantar plate? As we've discussed, we place a maglanomery elevator to release the plantar plate off of the metatarsal head, and that is stripping some blood supply off of the metatarsal head. And then additionally, in the traditional plantar plate repair, we're cutting the plantar plate off of the proximal phalanx. So we're removing two sources of blood supply to the plantar plate, leaving us with only the plantar fascia contribution of the blood supply to the plantar plate. So it could be that we're getting residual deformity because the plantar plate is essentially being killed and can stretch out. An alternative explanation is that by releasing the plantar plate from the metatarsal head is kind of like this, where, if you're trying to plug in an iPad, but it won't reach the wall, rather than moving the iPad closer to the wall, you pull the cord out of the wall. And even though you're attached distally, proximally, you're still unplugged, and that may be the reason why the MTP joint could still be unstable, leading to floating toes. So maybe we shouldn't be putting the maglanomery elevator in there and stripping the plantar plate from the metatarsal. And as mentioned before, this will allow for about 4 millimeters of distraction of the MTP joint. So maybe we shouldn't be placing the maglanomery elevator, or if you are going to place the maglanomery elevator, maybe we should be putting a suture in additionally and fixing it to the metatarsal head. But here's the way that I've been doing it over the past couple of years, where again, that's the normal one. Here's the abnormal joint where there's a lot of hyperextension. And so, the goal here is we got to pass a stitch through the plantar plate. So I'll make the traditional dorsal approach. I will do a plantar condylectomy because that's what we want the ligament to heal to at the end of the case. And if the plantar plate is intact distally, then I won't cut it off the phalanx. And what I'll do instead is I'll pass a stitch, and I want to pass a mattress stitch. So the green ribbon here is the plantar plate. The white thing is the flexor tendon. And what I've done here is I've passed a stitch through the plantar plate, and I'll rewind it just a little bit so we can see again. So I'll put the needle through the plantar plate, and I will grab the needle on the plantar surface of the foot outside of the skin. Now the head of the needle won't come out the skin, and I'll pass the stitch like that through the plantar plate. And then I will fix the ligament to the metatarsal. And this is done without cutting the ligament off of the phalanx. So here it is again, and I'll bring it back here so we can see again. So I'm passing the needle through the plantar plate. I'm grabbing the needle on the plantar surface of the foot, and I'm redirecting the needle after the stitch part has gone through the plantar plate, and I'll redirect it dorsally. So I've passed a mattress stitch. I paste two bone tunnels into the metatarsal and use a suture passer to bring the sutures to the dorsal part of the metatarsal head, and then I'll tie the sutures there. So again, I did not release the plantar plate off of the phalanx, and it's quite stable there. Post-operatively, I place this kind of dressing to hold the MTP joint in some slight plantar flexion. So doing it with this method of repairing the plantar plate proximally to the metatarsal, our results here are being prepared in a manuscript, but we did present this at the AOFAS summer meeting last year, and we found that after a median of 13 months, patients' physical function promise scores are at 52.5, which is considered to be in the normal range and loosely translates to patients who can do all of their activities of daily living, plus some strenuous activities. So in conclusion, plantar plate tears lead to instability of the MTP joint, and the MTP instability will lead to pain, metatarsalgia, synovitis, and eventually the dorsiflex and subluxated MTP joint will lead to hammer toes. Metatarsal osteotomies and toe pinnings are probably the usual treatment. However, a plantar plate repair is anatomic and addresses the root cause. Thank you for your attention and thank you for this opportunity. And feel free to email me at this email address if anybody has any questions. Thank you so much.